There are several causes of small bowel obstruction. Easy way of sitting and classifying them is like so. Intra-luminal causes are bezoars, several stercolates, foreign bodies, gallstone, INISS. Talk about mural causes. These are patients who are having neoplasms, although they are very rare. Usually, you'll end up seeing strictures from TB, Crohn's, or from prior radiation. Now you have extra-luminal causes such as hernias, adhesive bands, peritoneal deposits. So these could either be carcinomatosis from intra-abdominal malignancies, or it could be a non-abdominal primary. That's rare, but definitely possible. You could also have intraperitoneal abscesses, and there are these sort of extra-luminal miscellaneous causes such as intussusceptions and volvuluses. Okay, very crude sort of classification, but definitely logical. By and large, adhesions are the most common cause of small bowel obstruction. In the West, Crohn's disease is an extremely high number, but in our country, it's going to be on the lesser side. Hernias, again, is more common in our country, but less common abroad. Neoplasms entirely. Now, these are patients with advanced visceral malignancies, not necessarily small bowel malignancies. So when you're sitting and seeing neoplasms being a big cause, or rather I should say a sizable chunk of small bowel obstructions, remember it's not just a small bowel that we're sitting and talking about. It could be any intraperitoneal malignancy manifesting as small bowel obstruction. Adhesive obstruction, since it's the most common, needs to be tackled first. There are several predisposing factors, the first of which is gynae surgeries, right? For whatever reason, when we have either OBGYN surgeries, or rather I should be a little more politically correct and say pelvic surgeries, like even an appendectomy, you'll end up having a higher risk of adhesions. The logic is this: the transverse colon, the jejunum, the stomach, all of this is fairly well attached to the posterior abdominal wall in the upper abdomen, and the mesenteries are relatively short. Whereas when we talk about the terminal ileum, the mesentery is relatively long and the entire bowel rather more mobile. So whenever you undergo a pelvic surgery, adhesions form fairly quickly with the terminal ileum, and you can land up having several adhesions and a sort of localized volvulus around adhesive bands or bands that cause segmental obstruction on the small bowel. So pelvic surgeries are definitely predisposing factors. If a patient has had foreign material, or rather I should say permanent material implanted at the past surgery site, it could be silk sutures, polypropylene sutures, it could be a mesh. If the patient has had repeated surgeries, excessive energy use, several raw areas, particularly when you're sitting and performing dissection onto the retroperitoneum. Like for example, when you're doing nephrectomies or when you're doing colectomies, you have a large raw area that's left behind, and that area can be the cause of obstruction. What exactly is the lifetime risk? Well, if you have undergone any abdominal surgery in the past, you have a 4% risk of hospitalization for acute or subacute obstruction, and you have a 2% risk of intervention. This I'm talking about is a lifetime risk. All right. The typical features of obstruction are this: usually small bowel. Adhesive obstruction of the large bowel is extremely rare. Even when you are specifically performing pelvic surgeries involving the colon, usually the adhesions are still going to be involving the colon, but the obstructions that we get in the distant postoperative period are as a result of the anastomosis developing a stricture or the pathology recurring. It's very rarely because of any adhesive bands. So colon rarely involved. And usually a single band is to blame. Now, most of these adhesive obstructions are taken up for a conservative line of management. Thankfully, a vast majority of them respond to that, but do it for no more than 72 hours. Now, see, it makes sense, right? Think of what we discussed when we were talking about the oral contrast challenge. It is 48 hours initially before we give the challenge and 24 hours for the contrast to kind of find its way into the colon. So at the very least, these guys should be conservatively managed for 72 hours. Okay, don't try to be hasty. You'll end up performing another intervention and the patient is only going to have a chance of adhesion recur after that. You need to run the entire bowel, but if the patient is having several adhesions, then lies only the offending adhesion. Now, beyond this, you may land up having a patient where several adhesive bands are there and the bowel appears to be dilated in a segmental fashion all along its length. Then you only land up dividing with cold scissors with minimal use of surgical energy the bands that you feel are going to cause a problem somewhere in the future. Use minimal use of energy. Cold scissors, I can't repeat that enough, because wherever you will end up using an electrocautery, you will end up having a small area of soft tissue necrosis where the cautery has been fired, and that could be the point at which a fresh adhesive band could form. Laparoscopy, can it be performed for acute obstruction? Yes, it definitely can, but it is most likely to be successful and will have a lower chance of complications if the abdominal distension is not that severe, if the patient is having a subacute recurrent course, and if it is an adhesive obstruction. If you are thinking of any other cause such as Crohn's, then a laparoscopy is definitely not going to be of much value. So prevention is better than a laparotomy. Doesn't take a high IQ to determine that. So is there something that you can do at the time of your current surgeries to reduce the risk of adhesions long term? Yes, you definitely can. Go for a laparoscopic surgery. That's the first thing. Open surgeries are known to produce worse adhesions. Cover all the raw areas as much as possible. Use the omentum liberally, and don't land up performing omentectomies just because they're getting in your way. Remember, the omentum is a great natural anti-adhesive barrier. Use absorbable sutures. The total amount of foreign material that remains within the abdominal cavity is directly proportional to how dense and plentiful the adhesions are going to be eventually. So try to use absorbable sutures as much as possible. Something like polyglactin, polydioxanone are definitely going to be better than silk sutures or polypropylene sutures, which land up having fibrous bands. Silk sutures are especially notorious. Even though they are permanent, they lose a lot of their tensile strength, over half, within a few weeks after implanting, and the silk lands up causing a significant inflammatory reaction that worsens the risk of adhesions in the long term. So if you guys are still using silk, definitely reconsider. Also, as I just told you guys, use minimal surgical energy. And there are certain other tricks that you can use, right? Try to minimize mops and gauze contact, because mops will end up making the entire area extremely dry. They'll end up causing inflammation in the long term. You may have gauze pieces sitting in, giving out small little linen fragments that stay behind in the abdominal cavity, again a cause for chronic adhesions and small little infected sinuses to form. Give liberal washes. Don't leave behind blood clots and particulate matter. Try to give as much of a wash as possible. And specific anti-adhesive barriers are available. They usually have a hyaluronate based biomembrane. Now, there are membranes that are available that you just place on the visceral structures and then you close the abdomen on top of them. It has been found that it is more helpful to put several membranes all across within the abdominal cavity, and this has been found to reduce adhesive risk. But of course, this comes at a cost. A lot of people have experimented with giving antibiotic lavages, pulse lavages, trying to put in heparin and a bunch of other things, but usually does not really help too much. So if somebody asks me, what specific things that you can do for preventing adhesions, yeah, from a commercial standpoint, this is it. But it is a simple stuff that usually helps the most. Something as simple as not using powdered gloves and shifting to powder-free gloves can go a long way in reducing adhesions within your operative field. What can I say about hernias that hasn't already been covered? Now, these are usually symptomatic, right? They cause closed loop obstructions, and therefore these patients frequently find themselves on the operating table more often than not. The approach you take for these patients entirely depends upon the pathology that you're sitting and managing. You may land up performing a laparotomy if it's a complex incisional, but if it's a fairly straightforward obstructed inguinal, just a local exploration will suffice. There's another discussion altogether regarding whether to put in a mesh in these sort of fields. I'm going to leave that for the person covering hernias to talk about. Now, I've spoken to you about external hernias over and over again, but the same thing can also happen internally. Now, if you do a lot of GI surgery, and especially if you're veering into bariatric surgery, you will end up seeing some amount of acquired internal hernias. These are extremely rare without a previous surgery and usually occur after a Roux en Y. Change the pen color. All right. So the first area, if you've done a retrocolic Roux en Y, that you can land up having an internal hernia is this mesocolic defect over here. Essentially, what will happen is this entire Roux loop will end up finding its way into the lesser sac and telescope across this. So what you do want to land up doing in such a situation is suturing this bowel to the transverse mesocolon and closing that defect as much as possible so that telescoping is prevented. The second place that you'll end up having a herniation is in the intermesenteric defect that lies just beyond the jejunal-jejunostomy. In such a situation, the mesentery over here needs to be sutured together, otherwise you can have an internal hernia across this. And the last one, which is the most difficult for people to understand, as well as the one that is most confusing on table, I can tell you from experience, is the Peterson defect that occurs behind the Roux limb. It's essentially occurring in the greater sac below the transverse mesocolon, between the Roux limb and the retroperitoneum. So Peterson's defects are a little difficult, but remember, it's easy to prevent. Essentially, this entire area is closed off onto the transverse mesocolon, and you'll end up taking care of that. So prevention, again, is much better than actually curing these issues. Internal hernias can also occur in a congenital format. This is a patient that has a right paraduodenal and mesocolic hernia. This is essentially because the prearterial segment did not rotate. So this is a problem of malrotation of the bowel. It's a congenital issue. So you have all of this duodenum that is existing behind the right side of the colon's mesocolon. Now, what happens in this situation is, if you try to attack it like any hernia, where you open up the neck of the sac first, well, the neck of the sac actually contains the superior mesenteric vessel and its branches over here. So you clearly can't sit and do that. So what you actually land up doing is dividing the parietal attachments of the ascending mesocolon. What it lands up doing is, all of the colon now goes towards the left side of the abdomen, and all of this small bowel goes towards the right upper quadrant of the abdomen. So now the arrangement of the bowel is such that the entire bowel is non-rotated, essentially. If there's a right paraduodenal hernia, obviously there's going to be a left one, right? Well, here the small bowel is actually herniated in a small defect that exists just to the right of the inferior mesenteric vein and the retroperitoneum. So all of the bowel lands up going behind the left colon's mesocolon. Now again, you can't sit and attack the neck of the hernia in an unabashed fashion. You need to be very aware that the inferior mesenteric vessels are on the left side of the patient, and whatever cutting you have to do has to happen more medial to that. Otherwise, you're going to land up devascularizing the entire left colon. There are a few other extra-luminal causes. So if you're dealing with an intra-abdominal abscess, you would do well to perform a CT guided drainage first. Because remember, these patients don't have an intra-luminal cause. It's a localized ileus. So if you just land up taking care of the abscess, you should be good to go. The other thing about neoplasms is that they could have an abdominal primary. These are more common. Non-abdominal cases are rare. Small bowel neoplasms are rarer. The Mural clauses include malrotations and duplications. I'm going to leave it to Dr. Vinayak Rangan to take care of that. As far as the inflammatory causes go, Crohn's usually settles with steroids. But in a patient who has recurrent small bowel obstruction, good candidates for enteroclysis, right? They can have several strictures. You can't keep performing bowel resections in these patients because you'll end up with short bowel syndrome. So you may land up performing stricturoplasties in patients with Crohn's with intractable recurrent obstructions. Tuberculosis, again, it depends upon the pathology, may need resections. You start the patient on AKT and you hope for the best. Or in rare cases, if you've lost too much bowel with the earlier surgeries, you can land up performing stricturoplasties as well. Diverticulitis is not really going to be a small bowel cause, right? It's more often with the large bowel. They land up with pericolonic abscesses that cause localized ileus within the small bowel. So that's that. Radiation enteropathy land up causing cocoon abdomens. These are notorious. If you land up thinking about doing surgeries in these cases, you may have several enterotomies and not be able to do anything productive for the patient. So an initial conservative line of management, that's maybe slightly too conservative, may be a good idea in most of these cases. And last one is an ischemic stricture. Once again, you need to figure out on CT angiography what exactly the problem is, quantify that, take these patients up for surgery, either bypass the area or land up performing a resection with an anastomosis. So I've already covered strictures in the earlier one, so I won't do that again. A few intraluminal causes that we need to discuss. So very rare to have food causing obstruction, but it definitely is possible. but it is usually in the setting of a patient who has undergone a gastrectomy, either a partial or a complete gastrectomy in the past. These guys are very, very difficult to diagnose, even on CT. When we talk about bezoars, there are a few predisposing factors. The first of which is a high fiber diet. The second one is poor chewing by the patient. The third one is hypochlorhydria, either as a result of a patient having undergone a gastrectomy or the patient having chronic PPI therapy. Beyond that, poor gastrointestinal transit in certain patients can all contribute to either phytobezoars, which is vegetable matter, or trichobezoars, which is hair, and even pharmacobezoars, which are medicines, particularly herbal medications that can come and cause problems and impact themselves. Foreign bodies usually get stuck at IC because that is one of the narrowest paths. These are apparent on imaging and need to be managed. The most common worm causing obstruction is Ascaris. The obstruction is paradoxically precipitated by deworming. In such a situation, the several worms, perhaps in the 100, that have attached themselves to the mucosa all across the intestine, find themselves at the mercy of these antiparasitic agents. They all land up detaching, move together in unison towards the terminal ileum, and land up causing impaction and eventual obstruction. Ascaris is the most common one. There's nothing much that we need to talk about there. Gallstone ileus is an interesting pathology that I'll take a moment discussing. So essentially what ends up happening is these patients, they have recurrent cholecystitis with chronic inflammation around the gallbladder. Usually there is impaction of a stone at the cystic duct or at the infundibulum that doesn't allow the gallbladder to decompress. The gallbladder finds a different route. It forms a fistula into the duodenum. So you now have a cholecysto-duodenal fistula, as a result of which stones within the gallbladder can now find their way within the intestinal lumen. These stones frequently get impacted within the last 2 feet of the ileum, and as I mentioned earlier, there is a ball valve mechanism. The obstruction may not be absolute. This little stone may be moving back and forth and causing a waxing and waning sort of picture. Wriggler's triad is pathognomic for gallstone ileus, and it concerns 3 different things. One is a mineral deposit within the small intestine. Then there is small intestinal obstruction. You can clearly see the valvulae connivans have become very pronounced in this patient. And then, if you can notice this, there is air within the biliary tree. This air as a result of that cholecystoenteric fistula. Now, you only need 2 out of 3, which is seen in 50% of the cases. But even 2 out of 3 is pathognomic for gallstone ileus. Any of these 3, absolutely fine. How do you manage this? Well, it is usually diagnosed, sometimes intra-op if CTs have not been performed, or you need a laparotomy even if a CT has been done. You perform a limited laparotomy, pull the terminal ileum out. Now see, I said limited laparotomy, okay, when you know the diagnosis. You pull the ileum out, you milk the stone proximally, because usually if the stone has gotten impacted, the surrounding wall is going to be slightly ischemic. If you perform an enterotomy in that area to extract the stone, you may land up with a leak or a long-term stricture. So you milk the stone proximally, perform an enterotomy, get the stone out, and close transversely. All of these steps are extremely important. Okay. You must be asking, okay, you did a limited laparotomy for the terminal ileum, but you're definitely going to increase the laparotomy for the gallbladder, right? Absolutely not. The gallbladder is none of your business in a gallstone ileus. Because think back to this, there is a natural internal drainage that is now occurring between the gallbladder and the small bowel. if you try to take the gallbladder out, you're essentially going to be going through a chronically inflamed and fibrous area, and you have an extremely high chance of both a biliary injury as well as a duodenal injury. You may land up with a big rent in the D1 or D2 that you are just not able to manage within surgery. So let nature's natural internal drainage be for the time being. Don't try to do something heroic and land up with issues. So I actually needed to transition to large bowel pathologies because so far everything that I've gone and spoken about has been regarding the small bowel. And how do you transition to the large bowel in such a situation? Well, you kind of use an intussusception to segue into it, right? That's my one joke for the entire presentation. Okay, so an intussusception is a telescoping of one part of the bowel into the adjacent segment. That's exactly what it is. It is telescoping. This diagram from Bailey's is classical. You have the intussusceptum, which is going inside. You have the intussuscipiens, which is the outer rim. And can you notice this little circular area over here? This is usually the pathological lead point, which means that there has to be something within the bowel wall or inside the lumen and tethered to it that is causing this telescoping into the distal segment. Classically, though, intussusception occurs in male infants. The peak occurs at 5 to 10 month mark. There's a specific reason for that. It's because this is when weaning occurs. When the child is transitioning off breast milk onto solids, they'll end up getting a lot of extra pathogens within their milk that cause changes in immunity. Additionally, since breast milk is reducing, their maternal protective antibodies have gone down. The end result is that Peyer's patches become more pronounced and actually hypertrophy over a period of time. When you're less than 2 years of age, more than 90% of intussusceptions are idiopathic. Between 2 and 18 years, 65% are idiopathic. Most of these kids are less than 10 years of age. Greater than 18 years, almost none of these intussusceptions will be idiopathic. In fact, an intussusception in an adult is considered to be a big cause for worry, whereas they are considered to be fairly normal in very small kids. When we talk about the subtype, in kids, it is usually the ileocolic variety, whereas in adults, colocolic are more common. Clinical features is a small kid. Sorry, let me take care of that. Who is extremely irritable in episodes. The child cries, has legs drawn up. When you do a per abdominal examination, you will find an empty RIF. This is actually known as the sign of dance. You may find a sausage-shaped lump on the left side of the umbilicus. Classically, you will see red currant jelly stools. Now, why does this specifically occur? Now, what lands up happening is, at this apex of the intussusception, where the lead point is, this part of the mucosa is having its blood supply cut off. Because see, the deeper it goes in, the more its mesentery gets stretched and simultaneously compressed. So the mesenteric supply is compromised, the mucosa becomes ischemic and eventually sloughs off. So red currant jelly stools are a mixture of mucus, sloughed mucosa, and blood. These are the commonest clinical features in kids. When we are talking about an adult, they usually have all of the classic signs that we have spoken about earlier. Also remember, adult patients more likely have a lead point and a pathology associated with their intussusceptions, whereas for kids it is most likely idiopathic, which means the adult cases will be more symptomatic and will have more of the classic symptoms of intestinal obstruction as compared with children. When we're talking about imaging, again, when you're dealing with a distal block, it makes sense to give an enema. So this is an adult patient that has a colocolic intussusception. You can see a claw sign quite obviously over there on the enema. There are a few other signs that we need to talk about. The first of which is the target sign. You can see that lumen within lumen has actually produced this target or bullseye appearance within the bowel, which is pathognomic of intussusceptions. The other thing you may notice is a sausage-shaped swelling that is extending into the lumen. You may have to perform a multiplanar reconstruction to be able to get exactly this view, but it is seen in quite a few of these cases. The other thing you may notice, just pay attention to what's happening over here. This is a target sign. There's lumen within lumen, but can you see there is an area, bright white spots within the lumen? Those are not any sort of foreign bodies or opacities. That's actually contrast within the mesenteric vessels. So if you find mesenteric vessels within lumen, then that's highly likely that you're dealing with an intussusception. Now, how do you go about treating them? Most of these are very young kids. A pneumatic or hydrostatic reduction under image guidance will usually suffice. For most of the absolutely young children, within the first 4, 5, 6 years, sonography guided reduction is absolutely fine. You can see in this image over here, somebody is holding a sono probe and this kid has been sedated slightly, and they are performing the reduction through a Foley's that is inserted per anally. Now, the overall chance of success, whether you're using hydrostatic or pneumatic, which is either normal saline or air, for reduction is 70%. A few of these patients will require repeat procedures, failure of which may necessitate surgery. Overall, the chance of recurrence is around 10%, which I think is fairly good because entire thing is non-invasive. There are a few very important contraindications. If the patient is not vitally stable or is in shock, you can't take the patient up. Suspicion of strangulation, you can't do that. And finally, if the patient has a known lead point, then you should definitely not subject the patient to this intervention. The treatment for adults, no matter what, is always surgery. The reason for that is quite clear. If you're dealing with ileocolic intussusceptions, about 1/3 are malignant. If you're dealing with a colocolic, greater than half are malignant. So the pathology is a bigger problem than the obstruction and intussusception itself when you're dealing with an adult patient. Now, as a result of these very high chances of malignancies, most of these patients get oncological resections in an emergency itself without reduction of the intussusception. Meaning you're not sitting and pulling the segment out, because that's going to mean that you're risking more vascular compromise. You may risk tumor embolization through the vasculature, and it's going to prolong the surgery for no point. So most of these patients are offered oncological dissections. I can't stress this enough, without reduction.